Airway management in a critically ill
Recording in
child.
progress.
The objectives of today's lecture would be to understand the structured approach to airway and breathing in a critically ill child, and to introduce the equipment used to manage the airway, and to describe the skills which needs to be acquired in managing a child's airway. During the lecture today, we will be discussing on the following aspects of airway management in a child: the basic airway opening maneuvers, the airway adjuncts, the steps of intubation, and options for failed intubation. This will include the ordered sequential response and the simple techniques which are effective and life-saving, and also the other important steps that we can take when there's a failed intubation. Before discussing about the airway management in children, I want to highlight a few anatomical differences between a child and an adult, because this will be important in managing the airway. In younger children, especially the infants, they have a large occiput which can cause the neck to be flexed and can cause upper airway obstruction. That's why we always encourage to keep a shoulder roll for children of less than 2 years of age when managing their airway. And in young children, they have a relatively larger tongue when compared to the oral cavity, which can fall backwards and cause further upper airway obstruction. And in young children, the larynx is more high and anterior when compared to an older child or an adult. And also the epiglottis is more floppy, and these anatomical differences makes it a little more difficult in managing the airway in children when compared to an older child or an adult. Positioning of the airway in children. So in children of less than 1 year of age, infants, the airway opening position is the neutral position, as you can see on the first picture, where the face is parallel to the ceiling. The eyes are parallel to the ceiling, and there's no undue extension or flexion of the neck. In a child of more than 1 year of age, we maintain the airway in the sniffing position, as you can see on the second picture. You do a small head tilt and a chin lift and maintain the airway in the sniffing position of a child older than 1 year of age. There are 3 basic airway opening maneuvers: head tilt, chin lift, and the jaw thrust. As you can see on the first picture, with one of your hands, you can do the head tilt. You can keep the hand on the forehead of the child and do a small tilt. And with your other hand, you can do the chin lift and maintain the airway in either the neutral position or the sniffing position, depending on the child's age. When the airway cannot be opened by these 2 maneuvers, we can go for the jaw thrust, as seen on the second picture. This is an important maneuver to learn because there are instances where you cannot do the head tilt and chin lift, such as where you suspect a cervical spinal injury. In those instances, the jaw thrust would be a better maneuver to maintain the airway in a critically ill child. During the jaw thrust, you use both of your hands and keep the fingers on the jaw of the child and stabilize the cheeks with the thumb. And your aim is to push the jaw upwards and maintain the airway in a jaw thrust maneuver, as you can see on the second picture. There are various types of airway adjuncts that we use in a critically ill child to maintain the airway open. So first airway adjunct we are going to discuss is the oropharyngeal airway. So before inserting an oropharyngeal airway, you need to get the correct size of the oropharyngeal airway. So you size it by, as you can see on the first and the second picture, from the center of the mouth to the angle of the jaw. So from the center of the mouth to the angle of the jaw of the child, and that would be the ideal size for that specific child. And you need to keep one size smaller and one size bigger, because as you go in, sometimes you might feel the size is not exactly correct. So when you're inserting the oropharyngeal airway, it's better to do it under direct vision by using a tongue depressor or even your laryngoscope. And you insert it along the same anatomical pathway as your posterior palate, and you depress the tongue more than rotation, and you slowly insert it as along the posterior palate of the mouth. The next airway adjunct is the nasopharyngeal airway. This is not as commonly used as the oropharyngeal airway, but there may be certain instances that you might have to use this. For example, if there is significant trauma to the oral cavity, you might not be able to insert an oropharyngeal airway. Again, before you insert the nasopharyngeal airway, you need to get the correct size of the airway. So how do you get the correct size? The correct size of the nasopharyngeal airway is, the length is from the lateral edge of the nostril to the tragus of the ear, as you can see on this picture. Lateral edge of the nostril to the tragus of the ear. And the diameter of the nasopharyngeal airway is of the little finger of the patient or the diameter of the nostril. So nasopharyngeal airway insertion is a little cumbersome procedure and might be uncomfortable for the patient. So before insertion, you need to lubricate it well, and then, as shown on the picture, direct it posteriorly rather than upwards, and slowly insert it along the nasopharynx. The most important drug that we are going to deliver for a critically ill child is oxygen. In order to prevent hypoxia in a critically ill child, oxygenation is very, very important. And wherever you work, if you find a critically ill child that you need to resuscitate, you need to deliver the highest available oxygen concentration which is available at your hand. Usually this can be about 10 to 15 liters per minute. So the oxygenation for a child can be done by using various equipment. As you can see on this picture, you can use a Venturi mask where you can deliver a specific calculated amount of oxygen per minute. And in young children, especially infants of less than 2 years of age, you can use the nasal cannula or the nasal prongs, as you can see here. Usually the maximum amount of oxygenation that you can deliver through the nasal prongs is about 2 to 3 liters per minute. There are the normal face mask can also be used to deliver a higher amount of oxygen concentration. Oxygenation can also be done by using other advanced equipment such as the neopuff, the CPAP and the BiPAP. The neopuff is usually used for newborn resuscitation and for managing critically newborns in the NICU. As you can see on the first picture, you can deliver a specific amount of oxygen to the baby, and this is a more advanced method than the traditional bag and mask that we use for neonatal resuscitation. You need to deliver an exact amount of pressure which you can give through this, and that can provide effective oxygenation in newborn resuscitation. Continuous positive airway pressure, as you can see on the second picture, is also used to deliver a specific amount of oxygen concentration in the ICU or the high dependency units, especially for young infants in conditions such as bronchiolitis and other respiratory issues. BiPAP is not very commonly used in children, but also is used more of concentration, oxygen concentration. Bag and mask ventilation is one of the most important steps that we need to learn in order to effectively resuscitate a critically ill child. This will provide an effective oxygenation to the child until help arrives or until you go on for the next proper airway management. There are various size bags and masks to be used in children, and usually in newborns we use a bag of about 250 ml of volume, and for an older child it's about 400 ml. And then the TP's ventilation is not commonly used during resuscitation but commonly used by the anesthetist for various procedures done in children to provide some ventilatory breaths for a short duration. Before giving the bag and mask ventilation, you need to choose the correct size mask according to the child's size. The ideal mask should cover both nose and the mouth, but it should not go beyond the eyes and it should not go beyond the chin. So as you can see on this picture, this is the correct size mask for this child. If you use a too large mask, then the air escapes from below the chin and your eyes can get damaged. If you use a too small a mask, then your nose and mouth is hardly covered and you might not deliver the effective oxygenation to the child. Positioning of the mask is done by using the C and E method as shown on this picture. So the mask should cover both nose and the mouth, and you can use one hand in the form of the C and E method. So your index finger and the thumb is holding the mask tightly in the form of a C letter on the alphabet, while the other three fingers of your hand in the form of an E letter is holding the jaw, like in a jaw thrust maneuver. When you are doing this, remember not to unduly press on the throat area because that can cause upper airway obstruction. So this is the proper way of positioning of the mask before providing effective bag and mask ventilation. Bag and mask ventilation, the main aim is to give a volume of ventilation enough to produce an obvious chest rise. So it can be done by a single rescuer or ideally by more than one rescuer. So if you are the only rescuer available, you can give the bag and mask ventilation by yourself. From one hand, you can position the mask and hold it in the C and E position as shown on this picture, and then give the ventilatory breaths through the other hand. But you always have to look at the chest of the patient to see whether there is an obvious chest rise. When there is a single rescuer, this can be done for a short duration of time, but you cannot do it for a longer duration, and it can become less effective and difficult if you are the only rescuer. If you have another helper, then of course you can hold the mask. One person can hold the mask with both hands using the C and E position while looking at the chest, while the other person can give effective ventilatory breaths. This is the more effective and the easier method, and you can provide effective ventilatory breaths for a longer duration of time. Steps of intubation. So intubation is a skill that we all should learn, but it's not an easy skill to learn. To do an effective intubation, at least 4 members has to be there on the team. The team leader, and there has to be one nurse who is in charge of IV access and drugs, another nurse for the equipment used, and there should be a running person helping out the other members. So the main steps of intubation is pre-oxygenation. So the aim of pre-oxygenation is to get the oxygen concentration to a higher amount, at least more than 93%, before you start your intubation. So you do this by giving effective bag and mask ventilation. In children, as I have already mentioned, their larynx is high and anterior, so there has to be some person providing cricoid pressure in order for the team leader to do the effective intubation. All the drugs, the boluses and everything has to be predetermined according to the age and the weight of the child. And avoid ventilation if possible, but of course there are instances that you need to intubate and ventilate. In those instances, get all your things ready and intubate immediately without any delay, avoiding hypoxia of the patient. And once the tube position is confirmed, you can release the cricoid pressure. So as I have already mentioned, pre-oxygenation is where you get your oxygen concentration of the patient to a higher amount before attempting intubation. So you need to keep the child attached to the monitors, the pulse oximeters and the cardiac monitors, and provide effective bag and mask ventilation using the previous methods that we have discussed, and give effective ventilatory breaths for a couple of minutes until you get your oxygen saturation to a reasonable level. The nurse who is in charge of drugs should make sure that all the drugs are drawn according to the body weight and the age of the child. There are various drugs used prior to intubation, and it depends on each unit and the consultant as well. The usual drugs we use is a sedative, an induction agent, and a muscle relaxant. And you also need to make sure that all your resuscitation drugs such as adrenaline are ready, because sometimes the patient can go into a collapse during your intubation. And your fluid boluses also need to be ready, because the patient can suddenly become hypotensive during intubation. The nurse who is in charge of equipment should make sure that all the equipment are functioning. Battery life or connected to the electricity, and you should have the laryngoscope in place. Usually we use the straight blade laryngoscopes for younger children and the curved blades for older children. And your endotracheal tubes of various sizes according to the child's age and the weight, which we will discuss in the next slide. And your suction apparatus and the suction tubes. And all other equipment should be ready prior to the attempt of intubation. And the nurse who is in charge of equipment should make sure that these are ready. Is determined by age divided by 4 plus 4 for an uncuffed endotracheal tube. For example, if the child is 8 years of age, 8 divided by 4 is 2, 2 plus 4 is 6. So size 6 millimeter would fit for an 8-year-old child. But you always need to have one size above and one size below, because once you start intubating, you might realize that the size you are having at hand is not the exact size. For a term infant, the endotracheal tube is about 3.5 millimeter. For an older child, it's about 4 millimeter. And if it is a premature infant, the size is usually about 2.5 millimeters. The lip length of the endotracheal tube is calculated by age divided by 2 plus 12. So if the 8-year-old child, it's 8 divided by 2 is 4, 4 plus 12 is 16. So the lip level should be at 16. Steps of intubation. So prior to intubation, you need to make sure that you have pre-oxygenated the patient well and the saturations are at a reasonable level above 93%. And you can start using your laryngoscope and make sure that the laryngoscope is working before you insert it. And you push the tongue to one side and advance the laryngoscope further down. Once you come to the epiglottis or the vallicular level, you might not visualize the epiglottis and the airway because of the high and anterior larynx in young children. That's why another person needs to apply cricoid pressure as shown on this picture. By applying cricoid pressure, the epiglottis and the airway will be more visible. So once you visualize the epiglottis and the airway, you know that you are in the correct place. Once you see this, you need to start intubating using the correct size endotracheal tube. And you slowly advance it further down while withdrawing the laryngoscope outwards. Of course, this is easier said than done, so that's why it's always important to practice this skill whenever possible. So intubation might fail due to various reasons, but to make sure that you don't forget certain steps of intubation, there's a mnemonic called SOAP-ME. So S stands for suction. You need to make sure that the suction apparatus is working and proper suctioning of the patient, especially if there are secretions. Oxygenation, pre-oxygenation and checking for oxygen saturation. A is for airway adjuncts. While you get your equipment ready, you can always consider using an oropharyngeal airway and also keep the laryngeal mask airway at hand because you might fail the intubation. P is for positioning and pharmacology. So positioning of the child according to the child's age. Less than 1 year, it's the neutral position. Above 1 year, it's the sniffing position. Pharmacology indicates all the drugs that you are going to use at the intubation. M is for monitoring. Check all your equipment, the cardiac monitors, the saturation monitors, all should be working. And E is for escape plan and your proper size endotracheal tube. So you need to have a plan for failed intubation before you start intubating. After insertion of your endotracheal tube, you can confirm the position by various methods. First thing is to confirm the position clinically. You can see a nice chest expansion and your equal air entry when you listen from the stethoscope, and your saturations will start going up. You need to check for air leak on either side of the neck, and also you can confirm the position by using a carbon dioxide monitoring device. In uncuffed tubes, there might be a small leak. If you are using a cuffed tube, which is not commonly used in young children, make sure that it is not overinflated, because if overinflated, that can cause damage to the airway and laryngeal edema. And once you confirm the position, finally, you can confirm the position by taking a chest X-ray. So always remember, oxygenation is the most important step in airway management in a critically ill child. Before intubation, after intubation, and even after failed intubation, keep continuing to deliver proper oxygenation to the child to avoid hypoxia. Nasal intubation is not commonly used in children, but there might be children who have significant trauma to the oral cavity where you might have to put a nasal intubation to maintain the airway. If you have failed your intubation in 2 attempts, please continue your oxygen via bag and mask ventilation. Please don't hesitate to call for help. And always consider airway adjuncts such as the laryngeal mask airway, and also consider using other equipment such as the introducer or the bougie, or if final step is the surgical airway in failed intubation. And if you have failed in all the above other measures, you need to consider about a surgical airway. So this is the algorithm for rapid sequence induction. So you do a direct laryngoscopy and start intubating, as we have already discussed in the previous slides. If you succeed, then you need to confirm the tube position and continue to ventilate the patient. If you have failed in your first attempt, please call for help and start manually ventilating. If you can manually ventilate, reposition the patient and do 1 more attempt of direct laryngoscopy. If you succeed, Then confirm the tube position and continue to ventilate. If you are unable to manually ventilate this patient, then you need to start inserting a laryngeal mask airway, and through that you can provide ventilatory breaths. If that is working, then maintain ventilatory breaths until advanced airway techniques are being done or until help arrives. If the LMA is also not working, then you need to consider a surgical airway. This is called the vortex. So emergency surgical airway is here, but that is the last step that we are going to undertake in managing the airway. So your first step is effective ventilation through face mask, and then try endotracheal intubation. If unable, you need to make sure that you are going to get a supraglottic airway by using a laryngeal mask airway. So maximum 3 tries at each non-surgical airway technique, and at least 1 try should be by the most experienced available clinician. So maximum 3 tries at each of the non-surgical airway techniques, and at least 1 try of these should be by the most experienced person. If all these methods fail only, you will go for an emergency surgical airway and get the surgical or the ENT team involved. Laryngeal mask airway is another skill. Insertion of a LMA is another skill that we need to learn, because in a person who is, if you are unable to intubate or if you are unable to manually ventilate, LMA is a source of a source that you can provide oxygenation until further help arrives. So again, LMAs, there are various sizes according to the body weight and the size of the child. So you use the correct size, and with your index finger, so first of all you lubricate the end, and then with your index finger you slowly advance the LMA along the posterior palate of the patient. Before inserting it, you need to make sure that the cuff is deflated. Then you advance it further down, as you can see on this picture, with your index finger. You need to maintain the airway, as you can see here, in the correct position while you are inserting the LMA. Advance it further down, and at one point you will feel sort of like a give way sort of a feeling, and then you know that it's lying at the level of the epiglottis and the airway. Once you are at the correct position, you inflate the cuff and make sure that this lies in the correct place. And then you can connect your bag, the bag to the end of the tube and continue to ventilate through the LMA until further help arrives. There are rare instances where you cannot intubate or cannot oxygenate, which is actually quite rare in our setup. You might have to use various high-end equipment as shown on this picture, but I'm not going to elaborate on this because usually this is quite rare. And then the final option is a surgical airway. Can't intubate, can't oxygenate. Then you need to inform the surgical team or the ENT team and get a surgical airway in to maintain the oxygenation. So in summary of airway management in children, bag and mask ventilation and intubation are the most important skills that you need to learn, but these skills require time and practice to master it. And please never hesitate to call for help, even though you might be the most senior person in the unit at that moment. If you are not sure whether you can intubate, please never hesitate to call for help. And also have a plan for failed intubation before you start intubating. Ventilate as necessary and don't be afraid to assist. Maybe even to a junior person, don't be afraid to assist. And monitor effectiveness clinically and also by your other equipment to see whether you have effectively managed the airway in the critically ill child. Thank you.